So good afternoon, and I'm Marc Bourlière. I'm going to give you the take-home message for the second day of the PHC, Tuesday, 9th of March. So it was a very busy day in which we discussed a lot of things about hepatitis C elimination. Then we move about the HEV hepatitis management, and then we move to HCC. So let's begin with the first session, in which the title was Elimination for HEV by 2030 is realistic, and it was Europe versus the rest of the world. And for the European country, we had four speakers: Stanislas Paul from France, Stefan Zezem from Germany, Robert Flisak from Poland, and Vasily Isakov from Russia. And of course, everybody remained to this lab update analysis of HEV eliminations. And as you can see, among the high-income country, there will be only a quarter of them will be online and on track to achieve eliminations for 2030. And all this country had no restrictions for treatment according to fibrosis. But everything appears, despite the heterogeneous situation in each country, there is a lot of similitude for the conclusions. If we look at France, France is on track of HEV eliminations. However, eliminations goes beyond HEV elimination. It's also transformations of healthcare infrastructure. And there is some issue about the place of screening and access to care. And this is true not only for France, it's true for the other European country. And currently the situation in France is we try to multiply the micro-eliminations concept and additions of micro-eliminations who help the macro-eliminations. And currently in 2021, there will be around 86,000 patients who remain to be diagnosed and treated. The same is true for Germany. Germany is also on track to achieve elimination. However, there are similar problems that we observe in France. There is too low screening in persons who inject drug populations, and the treatment in these populations is also not enough engaged. And treatment is the same for treatment of HCC in prison. And so everybody is dealing with the same problem. That is, it's complicated to engage everybody in HCV care. And well, in Germany, like in France, we consider whether we can combine anti-COVID-19 testing strategy with HBS antigen and anti-HCV screening. In Poland and Central Europe, as reported by Robert Flisak, there is a major barrier, which is the lack of a national screening program and political wish to establish priority for HEV eliminations. And what Robert showed us is that the epidemic of COVID-19 leads to domestic reductions of treatment rates in 2020. So clearly, the HEV eliminations in Central Europe is not realistic by 2030. Vasily Isakov also shared the same concern about HEV eradication in Eastern Europe, and the barrier for elimination in all those countries are really similar. There is a low awareness of HEV among the population and among physicians. There is an underestimated economic burden, limited fund and resource for testing and universal treatment. So clearly in Eastern Europe, there is no one will reach the WHO eliminations goal by 2030. And the main concern in this country is that currently there is more new cases per year than a number of patients treated per year. So a huge concern in this place. Now, if we move to the rest of the world, as mentioned by Michael Fried and Raimundo Parada, either United States or Brazil will not achieve eliminations by 2030 due to multiple results. For the US, it's the result also of the importance of the opioid epidemics, which increase the number of new cases currently. There is also issue with the reimbursement purpose and the healthcare system, which in fact make the things not too easy to be done. And the same is true for Brazil, which is a huge country with a large number of patients. Despite the fact that there is a national plan in Brazil, the impact also of the COVID-19 pandemic on the HIV elimination was huge, and therefore everybody is faced to the same problem. If we move now to Asia, as reminded by Professor Jia, there is some progress that have been made around Asia. There is national action plan. There is significant price reductions of drugs, and there is reductions of price of the drugs and the comorbidities. And there is also hepatitis treatment, which is now covered by health insurance or governmental insurance. However, there is a remaining gap, which include a slow progress in harm reductions, especially in Southeast Asia. There is limited expansions of testing and treatment services, and there is a lack of systems to monitor progress. There is opportunity that include, there is a strong commitment to universal health coverage and primary health care. There is emphasis on integrations and overall system development. And there are enhanced interest in health and collaborations with community partners, including private sector. So what we could say about Southeast Asia is that everything is taking off. So elimination is taking off in Asia, but there is still some progress to be done. Now, if we move to the last, to Egypt. Egypt is a very interesting example, as mentioned by Professor Al-Ray. This is due to the fact that Egypt is going to be one of the first large HIV country which will be on track for eliminations. And I will strongly suggest everyone to look at the very nice article published in New England Journal of Medicine this year about the elimination campaign in Egypt. And it was a fantastic campaign in which during a 7-month period, 49 million people were screened, and among them 2.2 million people were HIV seropositive and referred for evaluations and treatment. And among them, among those treated and for which we have all the answer, there is more than 98% SVR. So that's a very huge effort. And really Egypt demonstrates that with a strong political commitment, with the development of a special task force, which involvement of media and social media in terms of awareness campaign, awareness about information and awareness campaign, with taking all that together, you can really achieve eliminations and screening and then treatment. So the remaining problem in Egypt currently is just to try to stimulate the effort of preventions against nosocomial infections, which still represent an important challenge to the healthcare system in Egypt. So Egypt is going to be one of the good examples for the rest of the world. So now let's move to the state-of-the-art lecture given by Jean-Marie Perron about the current management of hepatitis E. So as reminded by Jean-Marie, the surveillance of hepatitis E is high, the incidence is rising, and most cases go unnoticed. So when should we look for HEV? In fact, as reminded by the EASL guideline, in any acute viral hepatitis, we have to keep in mind that any suspect drug-induced viral liver injury should be tested for Hep E. Any decompensations, incompensated serologic, in decompensated serologic patients, we should think about Hep E. Of course, in any Guillain-Barré syndromes or neuralgic amyotrophy or encephalitis or myelitis, you may think about hepatitis E virus. And of course, you may think of that if you have any acute neurological symptoms associated with elevated liver enzyme. And elevated transaminase following transfusions also in these situations of post-transfusions hepatitis, you should think about hepatitis E. So diagnosis is simple. It's based on serology for the immunocompetent patients and on PCR in immunosuppressors patients. Treatment of acute hepatitis is à la carte. So we need to think about treatments by ribavirin monotherapy in those patients who had severe acute hepatitis E, in those who present with neurological injury, and in those who have acute hepatitis E and underlying cirrhosis, acute and chronic. And in these situations, we really need to consider to treat these patients with ribavirin monotherapy and monitor them. Of course, treatment with ribavirin is indicated in treatment of chronic hepatitis E. And what we need to do in this situation is we need to first reduce immunosuppressive drugs, and we need to begin by 3 months ribavirin therapy and look at HEV PCR in the stool at month 3. And if it's still positive, you need to go for 3 more months, 3 more months treatment. And interferon therapy can be had in case of ribavirin failure in selected patients, especially in patients with liver transplant or hematological malignancy or AIDS. Now we move to HCC. And so we have a very nice first sessions. We were moderated by Massimo Colombo with 3 fabulous speakers. And the first talk was given by Jessica Zuckman-Rossi about clinical applications of genetic in HCC. Then Valérie Paradis deal with the new pathology approach, and Valérie Villegrain deal with digital and imaging. So as reminded by Jessica Zuckman-Rossi, genetics can give a lot of things in both diagnosis and therapeutics in HCC. Constitutional and somatic genetics of HCC are highly related to environmental exposure and risk factor of HCC. Genomic of HCC is also related to the patient's and tumor phenotype and survival. And so therefore, the translation of genetics in clinics, it's really that genetics help us to improve diagnosis and it help us also to identify new therapeutic targets. Then Valérie Paradis told us about the what pathological approach can make in HCC. And of course, she demonstrated that pathological approach has a huge importance in terms of HCV, both diagnostic, but also and mainly on strategic choice of treatment. And it's really helped us to drive and to make the good choice and the good treatment choice for our HCC patients. Then Valérie Villegrain really demonstrate that with the big boost of digital imaging and deep learning algorithm, we are now be able to use this tool in order to improve our clinical capacity in terms of diagnostic and evaluations of treatments with this new technology. And so she showed us that there is a lot of studies who show the potential of quantitative imaging at different moments at different time of HCC evaluation, from both detections to assessments of tumor recurrence. And she really thinks, and she showed us the fact that clinical implementation is realistic when applied as a 2-step interpretation in synergy with classical human assessments. Human is still important, as mentioned by Valérie. And then we move to the second state-of-the-art lecture, which was given by Michael Fried about real-world evidence in HCC. And what Michael showed us is that, as everybody may remind, the treatment landscape is quickly evolving and providing better outcome for patients with HCC. And therefore, the problem, what's the real-world data can inform us about? In fact, real-world data can inform multiple phases of drug development. During the first 3 phases, the real-world evidence help us to identify unmet need. And then during the phase 4 post-marketing, real-world evidence can explain us how the thing is informing about clinical and policy decision. Of course, there is a gap between the scientific evidence given by phase 3 trial and the clinical use. And of course, what is mind the gap is the real world data. And what we need to have in mind when we think about real world data is the caveat that we have in terms of comparing comparative efficacy And we have to keep in mind that most real-world studies are rely on local standard to choose therapy for individual patients. And of course, there is some bias that can be introduced, either due to the physician's choice, the patient's choice, the payer choice, disease severity, and other intangible can impact the outcome. And so analysis must attempt to correct for the confounders. And that's why we use multivariate analysis, inverse probability weighting, and other methodology. So the benefit of the real-world evidence on HCC, but it's true on other pathology, as reminded by Michael Fried, is that real-world evidence provides important information about the natural history and treatment response in HCC. It helps us to evaluate the effectiveness of new treatment in populations underrepresented or not represented in clinical trial. Real-world evidence has contributed to optimize use in diverse populations and inform clinicians about safety and effectiveness. And the importance of real-world evidence from rigorously managed cohort will continue to evolve and give us inform on future clinical trial design, evaluations of unique combinations of therapy, and also lab expansion. So that's really the things that can be given by this real-world evidence data. And finally, the last sessions was devoted on HCC, evolving concepts in therapy. And first, George Lowe reminded and discussed the role of DA on HCC, and is going to show us how the data initially may suggest that they have a negative impact, and therefore there are several prospective data coming both from Europe and US who demonstrate no deleterious effect of DA, and of course the benefit of it on DA on HCC occurrence. And then we have a very nice talk from Vincenzo Mazzaferro about the indications and of transarterial radioembolizations in HCC, with all these benefits and limitations. And then Didier Samuel gave us a talk about the changing indications for liver transplantations. And of course, liver transplantations is based mainly on Milan criteria, which have some limitations. It's maybe excessive for early or very early tumor. It's too restrictive for lesions moderately above criteria. So now we have the preoperative AFP score, who improve the patient selections, allow reasonable expansions of criteria, and we have other biomarkers of gene signature are pending. They also spoke about the bridge treatment, which is required to control tumor progressions on the waiting list to downstage more advanced tumor. And there is in this setting new place for systemic therapy, as mentioned by Didier. And the current trend is really to do ablations and resections for a T1 single tumor, then salvage liver transplant. If recurrence, there is extension of transplant criteria to patients with elevated AFP and AFP score in France. So, and then we move to the nice talk about the new algorithms for systemic therapy given by Peter Gale. And as mentioned by Peter, the landscape of HCC treatment is rapidly evolving. And this year we have the Atezolizumab, which is now on board, and ipilimumab and nivolizumab have been also presented data. So for the new algorithm for systemic therapy in 2021, in the first line, we have both sorafenib and nivolumab in some country, but not in whole. And we have now atezolizumab and bevacizumab combinations therapy. And on the second line therapy, we have regorafenib, cabozantinib, pembrolizumab, nivolumab, ramucirumab, ipilimumab, and nivolumab. And that's the suggest proposal from Peter, is that if first-line treatment should be now atezolizumab and bevacizumab, and if there is any contraindications for these treatments, sorafenib or lorlatinib remain the first-line therapy. And then in second-line therapy, when you are dealing with first-line with sorafenib and nivolumab, you can go on regorafenib, cabozantinib, or ramucirumab. But if you are a failure on atezolizumab and bevacizumab, one of the propositions is to go on a multi-TKI as per off-label availability, so that's sorafenib, lenvatinib, and cabozantinib. And then for the last talk, Sandrine Febvre gave us a very nice other talk about the immunotherapy today. So as you can see, it was a very busy full day dealing with both HCC and HepC and HepE. I would like to thank all the speakers who provide me their presentations, and wish you a good night, and see you tomorrow for the third day of PHC. Thank you for your attention.